So I want to start by talking a little bit about my son Louis, who died following elective surgery at a teaching hospital at the age of 15. Louis was one of the top students in South Carolina. He was a soccer player, he was a musician, an actor, he was a natural comedian. I always feel as though I have to start out talking about him because this is what it is about. It's about him. It's about the patients who suffer because of the deficiencies in our system. Louis was athletic. He was absolutely healthy. His father and I thought that we were just the luckiest parents in the world. We thought we were raising the consummate man of the 21st century. But when Louis had just turned 15, we took him to the hospital for minimally invasive surgery, repair of pectus excavatum, a defect of the chest. The pain regimen following his surgery included the IV NSAID ketorolac. Because we blame this drug for a lot of what happened, I just want to add that even though it is widely used in American hospitals, it was never approved in most of Europe, and it's severely restricted in most other countries. And it's implicated in a surprising number of the cases that I hear of as an advocate for medical error victims. But briefly, the short story of what happened when we were in the hospital was that Louis was prescribed a full adult course of the drug ketorolac by a young senior resident who was following a written protocol and didn't realize the significance of the fact that Louis wasn't producing urine. His orders for IV fluids were also inadequate. He was apparently following the guidelines for a much younger child. It took 2 days of struggling with a disjointed parade of residents and nurses to get his orders changed and his IV fluids increased to an appropriate level. And by that time, apparently the damage had been done. Louis died 4 days after surgery from an NSAID-induced giant duodenal ulcer. His death was preceded by over 30 hours of alarming clinical decline, including more than 24 hours with virtually no urine output and 4 hours of completely undetectable blood pressure. It was the weekend. None of the young nurses or residents in the hospital had any comprehension of the severity of Louis's condition. To a person, they were convinced that his various abnormal vital signs were the result of malfunctioning equipment. On the morning of his death, they spent 2¼ hours scouring the hospital for a blood pressure cuff to detect his undetectable blood pressure. In all, they took his blood pressure 12 times using 7 different machines and cuffs. When he suddenly went into cardiac arrest, they were astonished. The resuscitation attempt was delayed, chaotic, and probably mercifully unsuccessful. Even at that juncture, no one thought to open up the spigot on the fluids. In Louis's chart, when we got it later, we found a plan of care. The plan essentially was that Louis would get better and go home. I was struck, as I had been in the hospital, by the fact that there appeared to be no accommodation for any deviation from the optimum. There was simply no plan for dealing with the complication, and consequently, it appeared that his symptoms had been downgraded in severity and reinterpreted to fit the preconception. The attending physician, whom we had repeatedly requested, had never been called. The rescue plan we had thought was about to swing into action at any minute had never even entered the minds of our son's young caregivers. The bottom line was that they didn't know what to do with a deteriorating patient, or apparently how to recognize even the signs of shock. As you can perhaps imagine, I spent months and years pondering circumstances that took our boy from robust health to death in 4 days. In Lewis's case, we always felt strongly that the primary culprit was the fragmentation and unresponsiveness of the resident care system. But it was also a nursing failure. At any point, I find it hard to imagine that this disaster could not have been averted by a vigilant, assertive nurse. Out of our entire hospital experience, the one person I cannot bring myself to forgive is a self-important nurse who artfully thwarted my attempts to reach the attending for reasons that are still unclear to me. At the same time, one of the few people who really helped us during this hospital stay was a knowledgeable nurse who was the person who managed to get the orders for Lewis's postoperative fluids increased after days of inaction by everybody else. But unfortunately for us, she came onto the scene a little too late. What are the lessons from this? Part of my crusade over the past 8 years, and this happened in November of 2000, part of my crusade has been on the theory that there are many teachable moments in what happened to our son. I don't want to sound presumptuous. I don't have any medical training. I don't even know exactly what goes on behind the scenes. But I'm going to give you a patient's thoughts after years of dealing with medical error victims, a dismayingly high number of whom, I should add, have been nurses who have helplessly watched as these conditions befell their own family members. But here are my thoughts. 1, the first issue is training. I have several points. Most of Lewis's nurses were very young. They were sweet. They were well-intentioned, they were articulate, but they clearly knew very little. Failure to rescue is distressingly common in hospitals, and it's primarily a nursing problem. I think that nurses at all levels need training and orientation on how to handle an emergency. I think they also need to know the side effects of medication, something that from a patient's perspective is taken entirely too casually by all branches of medicine. A corollary of that is the problem of task-oriented behavior. We were really sort of flabbergasted at the lack of goal-oriented behavior in the hospital. Lewis's vital signs were being taken regularly, like clockwork. They were going into the chart. I don't think anyone was looking at them, certainly not paying attention to them. It was just agonizingly obvious to us that almost everyone who was involved was performing tasks and not looking at the patient as a whole. I'm always haunted by the vision of our nurse spending a slow Sunday afternoon filling out that plan of care for Lewis to get better and go home, while dismissing the worried parents' concerns while her patient was going septic right across the hall. Nurses need to learn critical thinking. They need to be taught better ways to look at the patient as a whole, understand the goals for a patient. I think they just need to know more medicine. There's something I call misplaced professionalism, which really is just not listening to the patient. The idea that you know more about that patient than he knows about himself. I have long suspected that this is primarily a result of nurses, particularly younger and less thoroughly trained nurses, not knowing what to do, or conversely, knowing that in fact there isn't much they can do. It just strikes me as a sort of learned helplessness, a defensive reaction. Nurses, obviously, at all levels, again, need good communication skills. They need to know how to show empathy. And above all, they need to be given knowledge and confidence that there is indeed something they can do. They need backup. That, again, is the most alarming thing that I see. Better staffing, mentoring, rapid response teams have been something that I have worked on personally a lot, because I think it does provide a tremendous source of support for the patients. In South Carolina, we have passed a law on which I worked a lot. It's called the Lewis-Blackman Act, after my son, and it, among other things, provides that the patient has to have a number to call and that the nurse has to give the patient his or her attending physician's number or beeper number, which I've found that nurses use as backup because they have the law that says we have to do this. And they can say to the doctor, I have to do this. Sometimes mandates are backup. I think nurses need to be empowered as patient advocates, both morally and literally. Young nurses need to be acutely conscious at all times of their duty to advocate, and they need the knowledge and the courage to act on it. I think in this context that knowledge is its power. And finally, I think that patients need to be empowered and nurses need to learn to embrace that. Obviously, the empowered patient movement is happening because patients don't feel safe. And it will continue to happen no matter what the medical community does. But if nurses are explicitly taught how to deal with, how to interact the empowered patient, and how to encourage the timid patient, I think everyone can leverage this phenomenon to good effect. So I just want to close with something that all patients know, and I think all nurses know, but it sometimes gets lost in the bustle, which is that patient safety and quality is healthcare. It's very hard for patients to wrap their minds around the idea that there's anything else to it. In the end, it's all about taking care of the patient. You know, the frail elderly, the fragile newborn, the vulnerable heart patient, the frightened 15-year-old boy. Medicine, and particularly hospital care, may be a lot of things to a lot of people, but at the center of it is one nurse tending to one patient. Sometimes a lot of things get in the way of that. And it's our hope as patients to protect that relationship and help it blossom. I'll ask you all a question. How do you do it? If you assume that everyone wants to change the culture and make it more patient-centered, how do you do that? How do you teach that? Oh, well, we were helpless. We were not empowered at all.
What would have made you more empowered?
What would have made us more empowered would have been a nurse who listened to us, and because we were repeatedly asking for the attending physician, and there was a roadblock. Part of it was the nurse, and I think part of it was the physician himself. And those may not be entirely unrelated. What would have made us empowered, I think, would have been the ability to have a really good give and take discussion with the nurse and lay out a plan of action with her to say, you know, I will do this, I will call the attending, and, you know, I'll tell him this, and what do you want me to tell him? Discussion would have been a huge help. I think they didn't believe us, and if they had talked to us, you know, my son was a highly articulate teenager. There was no problem in communication from our side. And when I think about this happening to a family like ours, if you get someone who doesn't have those advantages, or a very small child who can't talk at all, it's a much worse situation. So, I think respect and interactivity is really the key to me.
The administrator on call has great impetus for things to go well, and the hospital operator always knows who that person is.
We know that now. On that day, I mean, if I can paint the picture, this was a Sunday afternoon. The hospital was just dead. There was no one there but the intern and the nurse. And they did not believe us, did not understand, did not believe that we knew that there was a serious problem. We couldn't think of a way to get around these roadblocks. We didn't know, we had no idea that the nurse even had a supervisor. The doctors were not in the hospital, not in their offices. We didn't know how to get hold of them. It actually didn't occur to me that they might have an answering service like a regular doctor. I just thought they were different because they were hospital doctors. In South Carolina, hospitals are required to give a certain amount of information about emergency numbers to patients. But of course they find ways to give that information that I'm not sure everyone would interpret as emergency.
You talked a lot about the individual's moral accountability, the lack of responsiveness you got in terms of people acknowledging theirs. I wonder what you observed about teams, either how the nursing team worked together, how the medical team worked together, or more importantly, how the entire healthcare team worked or did not work together.
To be perfectly honest, I didn't see any
Evidence.
Any evidence of teamwork at all on the
That was
part
my
of
fear.
anyone. Of course, people interacted out of my sight, but certainly there was not much sign that people even really knew each other.
I can recall an instance where the attending told me not to call him in the middle of the night. He did not want to be bothered.
Well, that's why we have rapid response teams, I think. How do you teach people not to be intimidated? I don't know, but I'm sure there are people who specialize in that. Disclosure of medical error is huge for many reasons, one of which is that it allows people to investigate the error and quantify the data instead of trying to hide it. Disclosure is a very big issue in the patient advocacy community because so many of these problems are driven by secrecy. And people are acutely aware of that. Again, you can see that the goal of the plan of care was to have a goal. Right. And instead it's become a process that detracts from the goal of caring for the patient. I think that was something that the people who started teaching systems theory in the early days of patient safety really didn't anticipate, and I'm not sure why not, that people would use it as a way of saying, well, there's no personal accountability then. Well, that's what people were trying to get away from with systems theory. But they were trying to get away from people blaming other practitioners. But what's happened in some cases is that everyone says, well, none of us are to blame. Going back to the idea of disclosure of error and the aftermath of error, it really is important, I think, that people step up to the plate and interact with the patient. One of the things that has been such a sorrow to me all these years is that I have never been able to talk to any of the frontline providers who were there because the hospital shielded them from us. The attending physicians who were not there were very available, but the residents and nurses were not. And it was important to me because it was important to me that they realized that this mattered, that this was a life and a promising, vibrant, young life that they should know about. It is so important, I think, for everyone involved that there be meaningful disclosure and accountability, that people really step forward and try to determine what their part was in this and what responsibility they may have had and what they can learn from it. I think there's a lot of healing that needs to take place on both parts if there's been a serious injury due to medical care. And that can't happen if everybody is trying to avoid thinking too hard about what their own actions may have contributed. So that's really important. And I think that for patients, the thought that something like this can happen without learning is awful. There's really nothing worse. It makes a life meaningless. You can destroy the meaning of a life in a moment if you do that.
Nightingale wrote, nurses, doctors, and administrators, each of them were what she referred to as a three-legged stool. And each of them had independent responsibilities. And she described that there should be a perpetual rub between them. They should always be operating from their own sphere in the best interests of the sick. That mechanism left us when that work was brought to America. They took and rejected just about all of what Nightingale stood for about the independence of nurses. You think it's time to bring it back?
Absolutely, I think it's time to bring it back. I think that nurses are the best ally that patients have in this fight. But I think that nurses and patients' interests align very closely on these patient care issues. The important message for faculty really would be to teach their students to be assertive, to stand up for themselves and for their patients, to really take it to heart to be an advocate for the patient. The patient has no other advocate, no better advocate than the nurse. Mm-hmm. So nurses need to stand up for their patients. They need to follow their instincts, and they need to be courageous.
They need to be courageous.
I think courage is an important component in all of this. When I look back at our story, I think that the failure of courage on the part of many people is really something that stands out.
To what degree do you think it would be helpful for institutions like the one your son was in to acknowledge that they do something other than patient care as a bona fide, actual mission?
I think it's very transparency in the residency care system. Transparency in teaching hospitals is really essential. It is outrageous that in this day and age people still try to keep it secret who is providing your medical care, and they do. Again, one of the components of the Lewis-Blackmun Act was that the hospitals have to tell people that they have students and residents, but they do it in a very general way. What we really wanted was names and levels of training. who would be in the operating room, who would be doing your surgery, who would be providing your postoperative care. It's very helpful if you know that your nurse is a student. If her knowledge seems limited, you'll know to call someone else. And that just in itself provides a safety mechanism for the patient, just that little bit of knowledge. So I assume it's on people's name badges here. In South Carolina, it's only South Carolina law, but I've noticed in years since that in other states I'll see people labeled resident instead of just saying Dr. Smith, which is a great advance. Because one of the things that happened with us was that the senior resident allowed us to believe that he was the attending we had called. I think internal medicine has a much more explicit policy that interns and residents are supposed to be given much more autonomy. I don't think any of the other fields have it quite so
Is this what you would argue against, the autonomy?
Yes. I don't think you can learn anything you're not taught. People they learn by guesswork, and if they pick up good habits, it's just by the grace of God. One of the issues that we have touched on is the idea of nursing culture, and that really is not so much a patient issue, but I think it's a very important one, how people deal with cultures that might be intimidating, that might not always end up being in the best interest of the patient. The question of how to empower nurses to do that. Nurse-patient ratios are very big to patients. I think that the failure to rescue question is huge. That is a nursing failure, and it is the most common aftermath of any medical error. They can start all sorts of ways, but they end up as failure to rescue. And that is something that needs to be carefully taught in a way that it remains uppermost in students' minds after they graduate, that this is what could happen. Mm-hmm. The worst case scenario is always a possibility.
It provokes me to think that in any student situation where they're learning in the clinical setting, one might almost provoke that thought about what would be the worst possible outcome here, what is likely to go wrong, so that you prompt the student to begin thinking in their minds of rescuing along the lines of what is likely to go wrong. That's an interesting thought.
Yes, it's very important, obviously, to eliminate the worst case scenario first.
Right. In many aspects of your story, we're about people thinking things were going right. Right. And not entertaining the notion that they could or were going wrong.
Yes, they made a lot of assumptions that this was a healthy child coming into the hospital for elective surgery. Their minds were not set to receive the idea of a complication. So no matter what went wrong, it didn't fall on fertile ground.
Right, right.
The idea that there was something wrong.
Right.
And my worries didn't penetrate.